you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
He's slightly intoxicated. You know, got his wrist pain by doing over-aggressive high fives to his buddies.
So have you digested the Carotid Flow Passive Leg Raise podcast yet? Hope so, because it's time for us to cram some more carotid flow, volume, responsiveness, hotness down your throat. This time we're talking about flow time though. Maybe a concept you haven't heard of. It's that smoking hot. But before we do that, an apology is in order. We mentioned on the last podcast about the course in Sweden in January. However, it's already full. No more room. And yes, the ultrasound course at SMAC is full also. And yes, you probably noticed on the CastleFest site that some of those packages are sold out, even though it's not until April. However, they're not all sold out. Only the King Queen package is sold out. As of right now, we've got room for you. And we're working on some new education to have at CastleFest that isn't even listed on the site right now. Just to give you a hint, it rhymes with transmanial poplar. There may be a podcast in the future on this as well, and we're excited to teach it during the Critical Care Day at CastleFest. But enough about that. Let's get back to the volume responsiveness. This is it, folks. The last of our 7 podcasts over 2 years on volume responsiveness.
Whoa, hold on a minute there. Before we go forward and talk about carotid flow time and all of its potential for awesomeness, let's talk about what we learned last week, the validated study that Paul Merrick and Alex Levitov put out, where they talked about an increase in carotid flow. Now, they said that an increase in carotid blood flow of 20% after a passive leg raise has a sensitivity of 94% and a specificity of 86% in diagnosing those patients who are going to be volume responsive. Here's an example of carotid flow on the left before the passive leg raise and carotid flow on the right after passive leg raise. And you can see they're actually able to have their machine calculate carotid flow for them. So here, 388 milliliters per minute before passive leg raise, 698 milliliters per minute after passive leg raise. Now, not all machines are going to be capable of doing this, so you might have to pull out your iPhone calculator. And if you do, this is the equation you're going to need. So take a quick screenshot of this so you have it available if you want to perform this maneuver on patients and decide if they're going to be volume responsive. The equation is carotid flow is equal to pi times the carotid diameter squared divided by 4 times VTI times heart rate. And remember, we said if that carotid flow increases by 20%, then the patient's going to be a responder. So what you do is you perform the passive leg raise while the patient's semi-recumbent here, and then you measure your carotid flow using that equation. And then you're going to elevate the patient's legs and perform your carotid flow measurement again. And this brings up an important concept. When we went over the echo measurement of volume responsiveness using VTIs, we were able to actually take the heart rate and the diameter, the LVOT, out of the equation. However, the carotid diameter does change before and after passive leg raise or before and after a fluid bolus is given. So you're going to have to keep the diameter in the actual measurement. That means you'll have to measure the diameter twice, before and after the passive leg raise maneuver. And that's an important difference between echocardiographic evaluation of volume responsiveness and carotid flow evaluation of volume responsiveness. So just to review one last time, you'll want to find the carotid and long axis, measure the diameter about 1 centimeter down from the bifurcation into the internal and the external carotid, and then place a Doppler gate right in the center of the carotid, making sure that your angle is perfect with the direction of flow, and then you're going to want to calculate your VTI. And remember, carotid flow, if it increases by 20% before and after a passive leg raise or a fluid bolus of 500 cc's, your sensitivity is 94% and your specificity is 86% for volume responsiveness. Now, something that we didn't mention in the last podcast is that all of these measurements are dependent on the angle of insonation, and that's the angle between the direction of your transducer and the direction of blood flow. Now, I want everyone to look at this slide and completely forget it as soon as I go to the next slide, because this stuff is a little too complicated to get too in-depth with. But you have to keep in mind that the more you change your angle, the lower your velocities are going to be. Now, what do I mean by that? Let's take this example. We have transducers A, B, C, and D. The only difference between the blood flow and the transducers is the angle that the transducer is hitting the blood cells at. Now, what happens is whenever you measure a Doppler shift, you're basically shooting an ultrasound wave at that moving structure, and then the frequency that returns back to the probe is going to change depending on how fast that structure is moving, whether it's moving towards the probe or whether it's moving away from the probe. And you can imagine that the vector of that cell moving towards the probe is different depending on the angle of insonation, or the angle that my probe is coming at towards the cell. So here, in this particular image, the transducer that's going to give me the greatest velocity is transducer A, because the angle is as close to parallel with the direction of flow as any of the other transducers. Now, B and C, my angle is more perpendicular to the direction of flow, right? So because of that, my velocities are going to decrease. And you can see down here in this image, velocities in C are very small. And then velocities in D are going to be completely reversed. They're going to be going the opposite direction, and that's because now the blood cells are moving away from the transducer itself. So why am I telling you all this? Well, mostly it's in preparation for this podcast itself. Because wouldn't it be great if we weren't measuring actual velocities, if we were just measuring the time of systole or the time of diastole? Now, I want to say that I am a little hesitant in releasing this podcast. This is an area that really hasn't been validated yet. We're talking about carotid flow time and corrected carotid flow time and how we can possibly use that in determining whether a patient is volume responsive. Now, this study that's currently being performed is being performed by some of the smartest people I know in bedside ultrasound. So I have trouble not giving them some fairly significant credit for it. But I just want to make sure that everyone understands that we are not actually saying that this is validated. This hasn't been published yet. We don't actually know what measurements you have to have or what changes in carotid flow time there have to be in order to actually say that someone is volume responsive. So take everything that we're saying with a grain of salt. All right, enough warnings for one podcast. Matt, take it away. All right, so I want to thank Vicki Noble and David Mckenzie for joining us to talk about the clinical application of carotid flow measurements in patients with volume responsiveness. Matt, you okay over there?
Yeah, I'm good, sorry.
All right.
Just for clarification, I'm not high. I know it appears so in the video, but I actually just woke up after 3 hours of sleep after 19 straight hours in the hospital. It was the only time we could get everyone together, so please excuse my appearance.
I guess I think everyone knows where Vicki's from. Vicki's at MGH. She's the ultrasound director and in charge of everything ultrasound all throughout the world. David, you just finished a fellowship with Vicki, is that right?
Yeah, that's correct. And I'm now at Maine Medical Center in Portland, Maine.
Awesome. And she has somehow convinced you to continue doing research with her despite the fact that you are states away?
Well, she's really twisting my arm, but she's got a long reach, it turns out, and so it just made sense to keep doing this.
All right, so I'd like to know, this carotid flow thing is interesting to me, especially because it's an alternative to getting echocardiographic VTIs, which I think is challenging for a lot of people. But I want to know, who are you applying this sort of use in? Like, who are you going to go in and measure carotid flow, do a passive leg raise, or give a fluid bolus to, and then measure the carotid flow again to see if they're responsive?
But I think one of the starting things is it really isn't for everyone, and it may turn out that this isn't even so much an emergency medicine thing, or it's not. Its greatest applicability may not be in the ED. It may be more in a critical care setting. I think the patient where it may make sense is someone who you're a couple liters into a resuscitation. Maybe you've already looked at their heart, or from a prior study that they have relatively poor reserve in terms of their ejection fraction, and you're questioning, does that third liter, does that fourth liter make sense? Am I going to hurt them with that additional liter of fluid? And I don't see that patient every day by any means. But when they turn up, they're usually someone sick, someone who needs a lot of resources and a lot of attention. And if you have the time and the energy and the curiosity, I think, to try and make the right decision, then doing a study like this, which may be technically more feasible than some of the alternatives and certainly less invasive, that's the sort of person you might want to pursue doing something like this in.
So you're talking specifically about patients with sepsis, right? I mean, let's just get that on the table first.
Yeah,
right?
and I think certainly we're thinking about sepsis. You can do this in anyone. Like, I was doing this in a guy with a GI bleed 2 days ago, and you can observe the response, and you can see that your resuscitation is working. But I think probably the setting where it's going to have the greatest applicability is in sepsis or hypotension, NOS, which we're certainly going to see some of, and it may turn out to be sepsis, but we may be treating a whole bunch of things at the same time.
So you're suggesting patients with sepsis,
And
specifically those people who you've started your resuscitation, but you're trying to decide, do I need to continue with fluid, or do I need to move to vasopressors, for example?
Yeah, I think that summarizes it. That's sort of the prototypical situation where you might use a test like this, where you're thinking, okay, I have someone who has become hypotensive. The working diagnosis is that this is sepsis causing it. and let's decide at this point whether I can keep going with fluid resuscitation or whether we need to switch over to something that's more invasive, either for central line placement, for pressors or monitoring and that sort of thing.
We actually had a great case last night of a guy who came in who was 76, who had, kind of poor reserves, bad ejection fraction, and had diarrhea. And he was like a GI bug kind of person, and you're not sure, is he kind of just need volume because he's lost a lot of fluids, or is he somebody who is now septic because he has E. coli bacteremia, and we're trying to figure out where he is on the curve and that kind of thing. So I think it's not just people who are fever and sepsis rule-outs, but the nice thing about the carotid, as opposed to cardiac stuff, no slams on cardiac, but like it's just much easier. So you can do it much in an earlier stage in your resuscitation, right?
I'm sorry, your audio just went out there. We lost you for about 15 seconds. So right after you said echoes awesome, I didn't hear anything else. So we'll try to get the audio back. No worries. So can somebody explain to me the physiology here? So why such a change in carotid flow before and after a fluid bolus, or before and after a passive leg raise? I mean, in that Merrick study, they cited like a 79% increase in carotid flow before and after passive leg raise, which is massive. I mean, when we look at stroke volume index, it's only an increase of like 10%. Why such a significant increase in the carotid artery? Anybody have an idea?
The response that they saw in that study was phenomenal, and not something that I think I'm seeing when I do this, and certainly not with flow time nor with VTI. And I think I'm not sure why that response was as great as it was. When I think of the sort of things that is sort of a typical threshold for is someone going to be a fluid responder, or did someone respond to that bolus? I kind of think on the order of 15%, maybe 20%. It's kind of both from a biologic plausibility and from from other measurements or predictors of volume response. And those are the kind of cutoffs that I'm typically seeing, and that I think we see in other applications. So I don't know why the flow increases that they saw in their study were so dramatic. Again, it was an ICU population of really sick people, but we're just not seeing that in terms of the numbers that we're getting or when I'm using this.
So David, you mentioned flow time. You guys are looking at flow time instead of VTI. Why flow time?
So flow time is kind of an outgrowth of esophageal Doppler monitoring, which is something that anesthesia and critical care has used at various points. And a lot of the credit for this, goes to Dave Blehar at UMass, who, published an abstract on this a couple of years ago. And in conversations with him, this is something that he had said, this is something, worth looking at. And sort of in preliminary work with it, it seemed kind of interesting. And it's dirt easy. That's one of the good reasons, I think, to do it. It's a very simple measurement to make. It's less intimidating. You can do it rapidly. Not that VTI through the carotid is as challenging as with echo, but this is even easier, which I think is one of the reasons to use flow time specifically.
Sorry, just one quick thing about flow time. The nice thing about flow time is when you look at VTI, you have to look at diameter of the carotid, because you're looking at the area and you're looking at the flow over the area to kind of measure output. But the nice thing about flow time is you're measuring relative changes in velocity. So if the velocity changes when you have passive leg raising, that means there's some capacitance within the system. And so it's a relative change that you're looking for. And so the diameter and all that stuff doesn't really matter, because you're measuring a 2-point curve, and you're seeing whether there's a change in the capacitance in those 2 points. And so that makes it, one less step. I mean, again, the diameter of the carotid is not hard to measure, but it's still kind of looking at real-time physiology, which I think makes it relatively stable within a certain patient population.
So it's cool that it's easy. It would be even cooler if it actually worked. What are you guys finding in your results?
So the setting where In terms of the study that we're doing right now, it's actually in a blood bank setting, so it's very controlled. It's people who, relatively young, healthy people who we know are coming in, presumably volume replete, and then we measure the flow time before the blood donation with a passive leg raise, and see that there's really no change in the system at that point, that their flow time stays constant. After they've been bloodlet, and they've lost 400, 500 cc's of whole blood, what you see is that their flow time sometimes will go down by as much as 25, 30%. If you perform a passive leg raise maneuver, you find that gets restored typically. And so it's really kind of a demonstration that in someone who is volume depleted, that performing a passive leg raise maneuver in conjunction with measurements of flow time is hopefully and probably going to turn out to be a reasonable predictor of who might respond to a bolus.
So it's fair enough to say that our listeners can go out and start measuring carotid flow times on their patients and make clinical decisions based on those changes in carotid flow time, right?
I don't know if we're quite there yet. I think
Yes.
this is...
Vicki Noble says yes. All right, we're done, everybody.
Vicki says yes. Why were you?
Well, but if you think about it, like honestly, if you think about it, it makes total sense, right? Like we're doing all these other sort of like secondary measures of what the capacitance of the system is and whether the venous system is full. And I think the nice thing about this, like what Dave is mentioning, the people who come to the blood bank also aren't totally tanked up. Like they're, usually drinking coffee before they come, and they're young, and maybe they need the money, or they're just good people. And so, whatever the reason is, like they come, and so they're not as, maybe volume full, but their system is what's the right word? Is like in homeostasis, basically. And so when you take away some of the blood from even those young, healthy people, that flow time change, I think, is more significant, because even if they're not fully volume full when they come in, they're compensated. That's the word, compensated. So they're compensated, and so their flow time doesn't change that much. But when you take away, a quarter of their blood volume or a sixth of their blood volume, then they are not compensated. And I think the thing we've always struggled with like IVC and all this other stuff is, you'll look at young students who are our models for all of our courses, and they've had 3 cups of coffee and their IVC is flat, but they're not volume down. They're compensated because they're young and they're healthy and their heart is working and they're not peripherally dilated. Whereas if you took away, a sixth of their blood volume, then all of a sudden they become uncompensated, and so that flow time change, I think, is more significant. So I do think it actually makes sense, and I do think, obviously it hasn't been tested in septic patients kind of in a randomized way, but I do think it has the potential there, just because I think it's easy and physiologically it makes a lot of sense.
All right, David, so this is one of the images that you sent us of carotid flow time. And it looks like a measurement very similar to what you would get measuring the VTI, which we've talked about already on the podcast. How is this different than measuring VTI?
So what you're just doing here is it's just a pure measurement of time. So the first caliper line there is at the upstroke of systole, and you've got a pulse wave coming through. And then the second one comes through at the dicrotic notch as the aortic valve is closing. And that sort of gives you your systole time. To measure a carotid flow time, or a corrected carotid flow time, you also need to measure essentially the cycle time, so a beat-to-beat measurement. And then the corrected carotid flow time is your measurement of systole time over the square root of cycle time, and that gives you a corrected flow time. And sort of a typical healthy person usually runs between around 330 milliseconds, and then in someone who is hypovolemic and responsive and has capacitance in the system, you'll see flow times go down to 260, 270 in that range. I had a guy, I was saying a couple days ago with a GI bleed, who his initial flow time when he came in with a blood pressure of 70/40, his initial flow time was down to 240. And by the time he'd gotten a couple units of blood and was going upstairs to the unit, his flow time, you could see, had serially expanded, and he was up to 340 by the time he was going upstairs. So you could really monitor his resuscitation. I mean, it wasn't a clinical conundrum in this case that he needed blood, but it was just a great illustration of the fact of how clearly this responds, and how easy it was to measure and monitor his resuscitation.
I heard you say the word square root in there. I do squares in my head all the time for fun, but for people who don't do that, is this on your computer or on your ultrasound machine? Is it an easy couple buttons to push, or you actually have to do the calculation?
I actually do the calculation just on my phone, and you know, the quick and dirty method is not even to do the square root part of it and just look at the uncorrected flow time. So that is from the point of the upstroke of the pulse contour wave to the dicrotic notch, and look at that. I think in a research setting, it certainly makes sense to use the square root and measure it as in corrected format. But if you're learning to use this and just trying to get approximations at the bedside and get familiar with it, you can follow even the time for systole, or the flow time itself, without correcting it, and you'll see changes. And you'll see changes after a passive leg raise in someone who's going to be responsive to fluid.
1.21 gigawatts! 1.21 gigawatts! Great Scott! What the hell is a gigawatt?
Let's look at exactly how to do this. Dave, take it away.
Hi, so I'm Dave Mckenzie. This is Scott Glazier. Hello. And we're going to show you the actual technique of measuring carotid flow time. So you're going to want to take the linear transducer, and this view may be familiar to you from placing central lines. The focus here, though, of course, is going to be on the carotid artery and not on the IJ. I find it easiest if you find an image of the carotid in short axis first, and then convert to a long axis view. Put your Doppler gate down, and then obtain a tracing. Every machine's going to be a little bit different, but the thing that you're interested in is in the flow time. That is the time from when systole starts to the dicrotic notch, identified by that depression there. And that's the carotid flow time. The key thing at this point is that you want to repeat this at some point after a volume challenge to see if the patient is truly volume responsive. And probably the easiest way to do that without actually giving them any intravenous fluid is to perform a passive leg raise. So in your patient, if you bring their legs up to about 45 degrees, hold it there for 45 seconds or so, then you can reassess them and remeasure flow time afterwards to see if there's been a change. An increase in the flow time of 15–20% probably suggests that your patient's going to be volume responsive.
So to get the corrected carotid flow time, which is what we really want to be accurate, you're going to have to do another measurement. Let's go over how to do that exactly. Remember, the carotid flow time equals the systole time divided by the cycle time, the square root of the cycle time. So your cycle time is from the beginning of systole to the next systole. Your systole time is going to be where you have the marks already, right here and here. So the carotid flow time is the systole time divided by the square root of the cycle time. So that's how you get your actual calculation before and after the passive leg raise. If you want their exact protocol, here it is. Take a quick screenshot of this and you'll have it forever. If you don't know how to take a screenshot, there's a really cool website that I recently discovered called google.com. Type in what you want to be able to do, and there's a pretty good chance it'll give you some search results on how to do that. I only mention that because, you know, teach a man to fish. So were you guys doing this before the blood donation as well, doing a passive leg raise on these people?
Yeah, and that's like an internal control. So a fairly typical scenario is that someone comes in, will measure a flow time as a base reading, do a passive leg raise. Typically, there's no change at all in the flow time immediately after the passive leg raise. Then, after they've been blood led, you remeasure the flow time. Typically, we'll see a decrease anywhere kind of on the order of anywhere from sort of 15 to 30% in most people. And then if you do the passive leg raise immediately after and auto bolus them, you see that the flow time goes back to what it was before the blood donation, which is kind of the demonstration that they should be fluid responsive, which is what you'd expect given that they've just lost a unit of blood.
Dave, there's something we didn't talk about during this whole conversation that I wanted to bring up real quick, and that's the importance of the fact that you're not actually measuring velocities, that you're measuring time rather than velocity. And maybe somebody said it and I was totally in Never Never Land, but the whole big thing about that is your angle of incidence doesn't matter anymore, right? You're just looking at the time of the ejection period. You're not looking, you don't have to be 180 degrees directed towards that flow. You don't have to adjust your angle so that you get the perfect angle on the vessel. That's actually a really big deal. That's big news.
That's part of the reason why we think this is cool, because certainly a VTI through the carotid I think is way easier than for most people than it's going to be with echo. But this even is like, again, fluid responsiveness for dummies. Like it's just that much easier, and it looks like it's going to work.
I've been training my fingers, and I think I could actually just feel someone's pulse and measure the ejection period. So I could probably just do these measurements myself. So what I'm going to start doing, I'm just going to put my finger on their carotid, raise their legs, and then if it feels like they've decreased their carotid flow time, then I'm going to give them more fluid. Does that sound reasonable?
Oh my God!
You laugh, but like
you're
when
totally.
When I was reading the IRB for this, or writing up the IRB for this, I went back and was, reading all these descriptions of these guys who, would feel pulse contours and make these calls and draw these sketches just based on feeling pulses. I mean, if you have that kind of skill in your hands, I'm just going to tip my hat to you and wonder what else you can do with those powers.
I don't, but I feel like there were definitely like 5 or 6 people at med school that did, like some of my professors, like the old curmudgeon-y guys that were like, blood pressure, they'd like feel the radial pulse, and they're like, blood pressure's 142/78 or something like that, and you look at the monitor and it's almost exactly right. It was ridiculous.
And he's like, and they've got a little bit of aortic stenosis.
Well, but that's
gradient, Like there are guys like that out there for sure.
I really want to thank you guys for coming on, and we appreciate you telling us a little bit about your study and giving us clinical expertise about how to use carotid flow in sick patients.
It's always good to see
guys.
Cutting edge bloodletting research coming out. I've also heard bloodletting is good for fixing your humors. Have you found that? So just to bring everyone back to earth, this is not proven. I know Vicki is brilliant, and Dave certainly seems so also, and this makes sense, and I hope it works. But this is currently being studied. It's not proven yet, which we're not telling you should start doing this immediately and that it definitely works. We bring this to you as next, what's coming. So play with it, try it out, and study it if you can. Tell us your thoughts. Let's move care forward together.
So one last thing, we're going to try a new segment at the end of some podcast where we get one of the founding fathers of emergency ultrasound, Chris Fox, to comment on what we just discussed. Naturally, we're calling it,
What Does the Fox Say?
So Chris, thanks for agreeing to our new What Does the Fox Say segment. I mean, it's not like you would have had a choice though. Had you not, we probably would have just asked you questions and clipped in random audio from past podcasts like the medical education one you did with us. So thanks. I just want to ask you a couple things. First off, how do you think we'll be able to convince people to start trying this out?
You need to tell them what it can do, how it's not dangerous, and that it's, even basics like there's no radiation, and that it can scan, everything from eyeballs to testicles. It's not just for babies and hearts. And I think that's a huge way, something needs to be overcome. A hurdle there is just educating people in a way that doesn't make you sound like a crazy zealot.
Okay. Not sure where testicles, babies, and hearts come in, but who am I to question the Fox? The real reason we wanted to have you on was for your sage wisdom. Mike and I tend to get a little excited when it comes to new research, and it's nice to have a reasonable, experienced person like yourself to really bring us back to earth and give a word of caution about applying new research too quickly. So this obviously isn't for everyone. Who, if anyone, should start applying this to determine volume responsiveness in these really sick, teetering on the verge patients?
I think it's going to be literally taught in home economics courses in high school. And I think, I'm not even joking, I think that everybody will look to ultrasound as something in the first aid kit, next to the Band-Aids. And
there you have it. The first of what we hope to be many What Does the Fox Say segments.
you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.